Again, the attendance is very thin. So today we'll be presenting one very interesting case. As you all know, rheumatology is a pure clinical science, and lot many times we have uncertainties. You have to be very good clinician to be diagnosing conditions and linking them together. So for this, I would invite Dr. Ranjan Gupta, faculty in the Department of Rheumatology, to take over from here.
Thank you, ma'am, and very good afternoon to everyone. So for today's case, we have brought to you a very interesting case. But before we start, we would like to acknowledge, first of all, the Department of Dermatology, because this case was actually admitted with the department and managed by rheumatology as well as dermatology. So the case history and everything has been taken by them. So big thanks to the department. And then, of course, the Department of Pathology and Department of Nephrology, who have helped us in getting the diagnosis and managing the case and the patient and his family. With this, I would like to invite our senior resident, Dr. Surya, to start the case.
Thank you, sir. Good afternoon, everyone. Coming to our case, Mr. A, 17-year-old male, presented to the AIIMS Dermatology Department in January 2024, with a history spanning over the past 2 years, with complaints of diffuse hair loss and weight loss, along with that proximal muscle weakness, Raynaud phenomenon, ulcers of the knuckles, and dyspnea on exertion for the past 6 months. And 2 months prior to the presentation, he had facial and palmar rash, swelling of hands and feet, ulcers over the elbows. Just to dig deeper into the history, he had diffuse global non-patchy hair loss associated with significant weight loss of over 37 kg for the past 2 years, associated with loss of appetite. For these complaints, he has gone to outside hospital. On evaluation, found to have mild pleural effusion with pleural analysis revealed elevated ADA and CB0 was negative. Autoimmune workup was inconclusive. So, just like in any Indian scenario with chronic history with significant constitutional symptoms, patient was started on empirical ATT. Patient has taken ATT for almost 6 months without any significant improvement. During the course of ATT, exactly after 4 months of ATT, patient developed proximal muscle weakness, bluish discoloration of bilateral fingers, also the knuckles, and also shortness of breath on exertion. Also, he had mild transaminitis, which was not up to the level of ATT-induced delight. So, patient was religiously taking ATT over the 6 months. But after 1 month of stopping ATT, patient developed facial and palmar rash, which was over the periorbital and malar area, swelling of the hands and the feet, and ulcers over the elbows, as you can see. On examination, patient had a very emaciated look. He was very conscious and coherent. There's mild pallor, edema of both hands, feet, and face, generalized facial erythematous rash, ulcers of the elbows and shoulders, gangrenous changes in the fingers and the fingertips. The systemic organ examination was pretty much normal, except for the proximal muscle weakness of the shoulder and the hip girdle. It was 3/5. Now, I would like to invite our dermatology colleague, Dr. Gauri.
Thank you, sir. I will be explaining the key findings in this patient. So, when the patient presented to us, he's a 16-year-old boy. So, he had diffuse erythema over his face. There was diffuse facial erythema, and that erythema was slightly attenuated over his periorbital areas, regions, and also over his bilateral cheeks. And there was spilling of erythema into the nasolabial fold as well. There was no sparing of the nasolabial fold. And the patient also had diffuse alopecia. There was a total diffuse alopecia, and there was no mucosal involvement. That is, the patient did not have any oral ulcers. And also, along with this, along with the erythema, there was no photosensitivity. And we can see that in this picture of the trunk examination, the patient had symmetrical involvement of the bilateral or the pressure points, that is the bilateral shoulders, the bilateral elbows, in the form of well-defined multiple punched out ulcers. These ulcers were ranging from size 1.1 to 2 into 2 centimeter. They were circular point shape with a clean base. And also these ulcers had peripheral hyperpigmentation in the margins, and some of them had hyperkeratotic margins. Here we can see the ulcers. Few of them were irregular and few of them were circular. And also similar ulcers were present over the metacarpophalangeal joints of the knuckles. They were not active, like the ulcers were of size 0.5 into 0.5 to 1 into 1 centimeter, with yellowish slough at the base and also peripheral erythema. And here we can see that the patient also had diffuse swelling of all the fingers and the hands, and also there were ulcers which were present at the digital tips, and also pulp infracts were also seen. And similarly, we could also see ulcers which were away from the digital tips. That is, there are ulcers also present over the palmar aspects, and also the patient had Desky fixed erythema. So to sum up, the patient had cutaneous ulcers, the patient had pulp infracts and digital tip ulcers and also palmar ulcers, and also the patient had facial erythema. Thank you.
Thank you, Dr. Gauri. Based on this clinical symptom complex and examination, we have gone for the further workup. Routines show that a patient had mild microcytic hyperchromic anemia with hemoglobin of 8.8, slightly elevated liver enzymes, AST and ALT were elevated, 86 and 163, and LDH was also elevated around 571. CPK was normal. On further workup of anemia, DCT was positive and HPLC showed beta thalassemia rate. HbA2 was around 6.8%. To our surprise, we found that urine routine showed 1 plus proteinuria on two separate occasions with no active sediments. On further workup, 24 hours proteinuria showed 1.3 grams per day, along with elevated inflammatory markers like ferritin was elevated. And PFT was done, which showed near normal PFT. So, based on the clinical symptom complex and all the laboratory workup, we had considered a possibility. Predominant symptom complex was myositis, which was more of hypomyopathic to myopathic dermatomyositis. Nephritis was in the range of nephritic range proteinuria, which was not in the range of nephrotic, and cutaneous in the form of Raynaud's and vasculitis, also in the background of predominant constitutional symptoms. So, the possible differentials we considered are mixed connective tissue disorder because of predominant Raynaud's, skin features, and myositis. And next, the flag bearer SLE because of the myositis and the nephritic component. And followed by that, overlap syndromes, inflammatory myositis with lupus nephritis, scleroderma with the lupus nephritis. And rare possible causes were myositis with amyloidosis and myositis with glomerulonephritis. In view of the possible differentials, we went with autoimmune workup. We showed low titer cytoplasmic ANA, specific autoantibody ENA profile was negative, normal complements dsDNA was negative. So, based on this, now we will discuss the points favoring the possible differentials and the points against the possible differentials. The SLA and MCTD, the clinical symptom complex, very much fitting into the SLA and MCTD, but the autoantibody profile was against it. ANA being negative to low titer, which was completely against, and UNRNP was negative, which is completely against MCTD. And complements being normal, literally ruled out the SLE. So the next possible conditions were overlap syndrome, inflammatory myositis with amyloidosis and glomerulonephritis. Myositis being the predominant condition. But amyloidosis usually presents with a very long history of inflammation. But patients, considering patient's history was short over a duration of 2 years, and patient had low-grade proteinuria, which is very unlikely for the amyloidosis. So, in view of myositis being the predominant component, we went ahead with myositis profile. Myositis profile turned out to be MDF5 strong positivity. And also, in nerve conduction studies was done, it was normal. EMG was suggestive of inflammatory myopathy because membrane instability. But there was still one lesion that has to be evaluated. That was a predominant, that was a high-grade proteinuria, which was around 1.3 grams per day. So we went ahead with the renal biopsy. Now I'd like to call upon Dr. Shivashankar from Department of Pathology.
Thank you, sir. So we received renal biopsy for this case comprising of single core of cortex We evaluated this biopsy using routine H&E stain and 3 stain, Pass, Jones, and mesotrichome. This renal biopsy comprises of 10 glomeruli, and in this image, in low power itself, we can see there is very less involvement of tubulointerstitial compartment. Just to see the tubulointerstitial compartment in this power, there is minimal interstitial inflammation, and IFTA is approximately 5%. IFTA is interstitial fibrosis and tubular atrophy. So on closer look to the glomeruli, this was one of the worst glomeruli which was affected, and you can see this these are the areas of mesangiolisis, very pale looking, and one of the capillaries, capillary lumen was occluded with fibrin-rich thrombus. This similar thrombus we can see on the PS stain, and these are the areas of mesangiolisis. This is the Jones silver methenamine stain. Similar thrombus we can see in this capillary lumen, and also extensive wrinkling of the glomerular basement membrane is also noted. In addition, few of the glomeruli also saw reduplication, as you can see here, 2 lines in the Jones silver methenamine stain, and this was not present in all the glomeruli. This is segmental involvement of the glomerulus. And arteries and arterioles are histologically and within normal limits. On immunofluorescence, immunoglobulin IgA, IgM, kappa, and lambda show non-specific trapping. So, on concluding till here, we thought there is no immune complex mediated injury going on in this case, but there is definitely chronic glomerular damage is happening in form of reduplication of glomerular basement membrane and nearly subacute changes in form of thrombus within the capillary lumen. So we went to do electron microscopy, and we just before that just have a look over the normal EM. Just this is the glomerular basement membrane, this is the food processes, and this is the endothelial lining, and this is the endothelial lining, and this is fenestra. So in this case, we can see there is fenestral fusion and marked endothelial damage in form of in the glomerular basement membrane duplication, and also some electron lucent material deposition in the subendothelial space. This is the higher power to show the areas of mesangiolisis, and this is one of the electron dense deposit which we have seen in the subendothelial space, represent hyaline-like material, but it is very non-specific. In addition, there are numerous myelin figures was also noted. Here again, this area is showing reduplication of the glomerular basement membrane and also electron lucent material deposition in the subendothelial space. This is again one photograph to show the presence of myelin figure. This myelin figure might be due to drug intake like hydroxychloroquine, maybe. And also there is present, in addition to endothelial damage, also there is presence of tubular reticular inclusions in the endothelial cytoplasm of the endothelial cells. This is the area of collagen deposition causing mesangio in the area of mesangiolysis, leading to sclerosis of the glomeruli. So, on summarizing the electron microscopic finding, there is endothelial swelling, fenestral fusion, subendothelial electron lucent material deposition, and basement membrane duplication. In addition, there is myelin figures, tubular reticular inclusion, subendothelial hyaline-like material, and also focal mesangial fibrosis was noted. So, diagnosis of glomerular thrombotic microangiopathy, which is subacute to chronic, and mild tubulointerstitial chronicity was given.
Thank you, Dr. Shivshankar, for the deeper insight into the renal findings and for revealing the true mechanism and answer, which is finally the thrombotic microangiopathy in MDF5 myositis. So, in view of renal findings suggestive of thrombotic microangiopathy, APLA profile was done which was triple negative. The anti-cardiolipin, anti-beta 2 GPI, and lupus anticoagulant all were negative. And ADAM TS13 levels were done, which was normal, and complements levels being normal, and clinical profile not suggestive of any hemolytic uremic syndrome type. So hemolytic uremic syndrome was not considered. So, considering the diagnosis of thrombotic microangiopathy with in MDFI myositis, patient was started with pulse methylprednisolone and along with tapering steroids and mycophenolate mofetil for over 1 year. Patient improved significantly after starting the treatment. His general condition has been improved. As you can see, the ulcers over the bilateral shoulders, bilateral elbows were completely healed, and also his hand pitches. Basically, when Dr. Gauri has previously defined, all the pulp infarcts, all the cutaneous findings which were seen, like inverse Gottran's, and which was very classical of MDFI dermatomyositis, is completely resolved in the post-treatment phase. And also his general condition was fairly improved. His hair growth was good. His general weight has been improved, and also his laboratory parameters were also improved. All the muscle enzymes, AST, ALT, and LDH were normalized. The CPK was pretty much normal from the baseline itself, and the renal component, which was the proteinuria, which has completely resolved. It is less than 500 currently. Now I would like to call Dr. Ranjan for a deeper insight into the review of literature and concluding remarks.
Thank you, Dr. Surya. So we'll just have a look into how common this kind of presentation is, and if there is, if that is the presentation, what is the prognosis of such patients. So as we all know, idiopathic inflammatory myositis is actually a clinico-biochemical diagnosis where we have the clinical presentation in the form of myositis, muscle weakness, and a biochemical signs of inflammation in the form of either antibodies or raised muscle enzymes. Now, it is a heterogeneous group of disorders where predominant symptom is muscle involvement. Along with that, multiple system involvement can be there like any other rheumatic disease. And as per today's understanding, we divide all inflammatory myositis into 6 groups. First being dermatomyositis, then we have anti-synthetase syndrome, necrotizing myopathies, we have inclusion body myositis, and then we have got bland polymyositis and some overlap myositis. All of them can usually involve one of these six systems or maybe a combination of it. Now, dermatomyositis is the flagship disease in this group, which classically has muscle and skin involvement. But sometimes, like we saw in our case, the muscle involvement can be minimal or it may not be there at all. And that is the time when we call it either a hypomyopathic dermatomyositis or we call it an amyopathic dermatomyositis. At times, the skin involvement may not be there. Patient may have an antibody which is associated with dermatomyositis, but on muscle biopsy, you can find myositis. Such patients are called dermatomyositis sign dermatitis. Now, these patients can have one of these 6 antibodies, either Me2 or it is MDF5, like in our case. It could be TIP1 gamma, NXP2, or SAE. Now, these antibodies have their classical features associated with it, and it's at times it's just a look of the patient that will tell you that this patient has this. Now, when this patient came to us, it was not very difficult to think of myositis, but then we needed to rule out other things because he had an odd presentation in terms of nephropathy. So that is when otherwise clinically his diagnosis with this myopathy would be MDF5 myositis. So this is a busy slide where I'm going to give you a small overview of how these myositis are associated with various antibodies. And the classical Scholl sign, V sign, and the heliotrope rash is now known as Me2 positive disease. MDF5 sits at the junction of patients who have either lung disease, skin disease, or both of them. Mechanic's hands usually seen in anti-synthetase syndrome. Now we come to our patient. Renal involvement is not explained in this group of patients. MDF5 is basically a melanoma differentiated associated protein antibody, and this has prominent 3 symptoms in the form of very severe interstitial lung disease causing ARDS, and at times that is the cause of death in these patients. They have myopathy, which is seen in only 50% of patients, and prominent skin and palmar ulcers. Now let's understand what is thrombotic microangiopathy. So I'll give you an analogy of Evans syndrome. We know it is a combination of immune-mediated destruction of thrombocytes and RBCs. When combined, we call them Evans syndrome. And this is usually immune-mediated. That is why most commonly seen in autoimmune diseases. That is why we have a DCT which is positive. Let's come to the other side, which is called TMA. Now, TMA is basically happens because of two problems, either of them. Either it is an ADAMTS13 deficiency causing platelets to aggregate, or there's a complement mediated platelet aggregation leading to thrombosis and then microangiopathic manifestations in the form of mental obtundation and nephritis. This is seen mostly in malignancies, infections, sometimes in autoimmune diseases, and since it is not directly immune mediated, we have DCT which is negative. The classical examples are PTP and HUS. Now, in literature, if we see this particular series saw their cases from 2001 to 2016, 159 cases, only 3 had TMA. So incidence was only 1.9%. But then they dug up all the cases from 1946 to 2016 and they could see only 13 more cases. And this is the overview of these cases. Since these cases are all old, when we did not have the facilities to test antibodies and ADMTS, you see their defining criteria was low platelet count. All of them had hemolytic anemia and almost all of them have neurological manifestations. What about MDFI myositis with TMA? So only single series from University of Tokyo in Japan, 13 years, they could find 26 cases of MDFI positive myositis and only 4 had TMA. Now, all these patients had hemolytic anemia and MMF was tried the most common medicine in all of them. Let's look at their protein creatinine ratio, which was higher than in those patients who did not have it. Then what is more striking was that almost all these 4 patients had very prominent lung involvement. They had inverse Gauthron sign and the ferritin, which was higher compared to patients who did not have TMA. So, thrombotic microangiopathy in MDFI, is it rare, or if rare, how rare? So we should suspect TMA whenever we have a clinical case who is having thrombocytopenia, hemolysis, and features of microvascular involvement in the form of CNS involvement or renal involvement. MDFI, as we showed, it's a combination of 3 systems, basically very prominent skin ulcers, rapidly progressive ILD leading on to ARDS and causing death, and at times hypomyopathic to amyopathic dermatomyositis. TMA as such is rare in inflammatory myopathies, only 1.9% is the incidence, and in MDFI it is even rare. The case that we have seen, and as per our possible search, we have made our best efforts, this is probably only the 6th case in the world that we would be reporting. These patients are also managed the same way as we see with other cases of myositis with prominent internal organ involvement, mycophenolate, cyclophosphamide, and rituximab. Our patient was later on given rituximab because the rash was persistent, even though he had responded, the renal parameters and muscle enzymes had responded. Prognosis, as per the only series available, it is same as in those patients who do not have TMA. With this, I would like to thank all the audience and we are open for questions. Thank you. With no questions, may I ask Dr. Arun, our omni-available nephrologist, to please give some comments about this patient who we had managed.
Thank you, sir. I think it was a very nice case presentation. Overall, most of the cases of myositis, they don't have any particular renal involvement. And most often, we don't biopsy because they have borderline proteinuria. And by the time immunosuppression is initiated for them, be it MMF or any other immunosuppression, the proteinuria subsides. That is probably one of the major reasons why we have not seen overt glomerular involvement in myositis per se. Usually, we have acute kidney injuries because of rhabdomyolysis. That is more common, which does not require a particular immunosuppressive therapy. The finding of TMA overall is important for us because if at all there is an underlying complement mediated cause, the long-term prognosis becomes bad. The need for long-term anti-complement therapies, which are now evolving, will be important. But these cases wherein it is not a complement mediated TMA, but rather secondary to dermatomyositis, probably with treatment of the inciting cause, it should get improved as in this case. And I think it has been very well managed. And probably there's a lesson for us that we'll have to have a lower threshold for biopsying in patients, especially with non-lupus like disorders, wherein the criteria is not very clear. Thank you.
May I invite some comments?
Thank you, Dr. Anjan. Of course, it's a lovely case, and just to tell the house, so when we got the biopsy on the form, we did not know the exact diagnosis. We usually have query lupus, query CTD sort of diagnosis. So for pathologists, it's important to understand that the pattern is actually an MPGN pattern because we see reduplications, and you can over interpret the immunofluorescence, and then it would create a lot of confusion. EM, of course, helped because we could really see the endothelial injury and the reduplication there. And in terms of pathogenesis, a lot of it is interferon driven, which we see in a lot of CTDs actually, and we see morphological evidence of that as the endothelial tubular-reticular inclusions that were demonstrated. But lovely case.
How common is the TMA that you have seen here in patients with
TMA in CTD are most common association is APLA. You know, these are lupus patients with a secondary APLA. Sometimes we do suspect primary APLA also. But with APLA, what happens is you have arterial involvement as well. That's usually quite classical, which, as Shiv showed, the arteries are fine and it's purely a glomerular TMA. In a pure glomerular TMA, in a CTD concept, I mean, atypical HUS. So then that would be the second. First, we think APLA, check the larger vessels, not involved, then we would think of atypical HUS. And I think both have been excluded quite confidently in this. I think it's the interferon excess in this myositis, the inflammatory myositis, which is driving the TMA.
Sir, which one, sir? Ah. So clinical symptoms are very classical. If we exclude nephritis, it is a spotter. So I'm not able to hear this. So Raynaud's can happen across the myositis. Except for one or two varieties, Raynaud's is a non-specific symptom. It does not include or exclude. Raynaud's can. So some of the, like there's another variety which we call antisynthetase syndrome. There also it's quite prominent. So Raynaud does not exclude or include the possibility of myositis, dermatomyositis. So if there are no questions, we would like to conclude our presentation and thank you for the patient here.